Good afternoon, everyone. Thank you, Yashoda Hospital and Dr. Nagarjuna, sir, for inviting me. It's a fantastic event, very insightful and very informative. So I've been given a talk regarding EBUS TBNA pitfalls. So we'll go down with, we'll first identify the potential complication. We'll discuss the way of reducing the risk of complication, how to deal with the occurring problems, and practical tips. So we all know, we have been reading a literature, and we know the complication that has been occurring with the EBUS TBNA, that it can cause an infection, mediastinitis, pericarditis. It causes bleeding also, hemoptysis, pericardial tamponade. It can cause a contamination of the tumor bed, and tumor spread, it can happen. Pneumothorax, hypoxia, inflammatory reaction. And with the device malfunction, it can cause a needle fracture, needle malfunction, spring malfunction, and scope damage. So we all know that EBUS TBNA is not free from any complication, and the bronchoscopist should be aware of the potential procedure-related infection. Widespread intrathoracic infection caused by EBUS TBNA on the following reason, that is radiographic evidence of the progression of the mediastinal lesion shortly after the procedure, temporal relationship between the infection and the procedure, and rare simultaneous occurrence of mediastinal abscess, empyema, and lung abscess, which suggest a complication of the invasive procedure. So when you actually go down and negotiate and try to take the pass with the help of a EBUS TBNA from the mediastinal lymph node or mediastinal mass, the infection can be introduced by the direct inoculation of the oral commensal into the target structure while repeatedly manipulating the aspiration needle through the working channel. Contamination of the TBNA needle with oropharyngeal flora is a common event during EBUS TBNA. And patient in a chronic debilitated condition may not be able to evoke a systemic inflammatory response, especially infected with low virulence organism. And this can lead to a process where the infection spread insidiously and widely. So there was a landmark paper, complication associated with EBUS guided TBNA needle, and it was by the Japanese. And the total EBUS TBNA were around 7,345 number of procedure, and causing damage. The site of damage was working channel, fiber portion, ultrasound probe, and other portion. But the complication rate were very minimal, 1.23%. And the infectious complication were mediastinitis, pneumonitis, pericarditis, cyst infection, septicemia, pneumothorax, and scope damage. There was one more paper, landmark paper in India, with a single center experience of 1,004 people undergoing EBUS TBNA, and they had reported a complication of 5.9%, where they had bleeding, mediastinitis, hypotension, respiratory failure, arrhythmia, sustained hypoxemia, transient chest pain, excessive coughing, and escalation in any level of care. I would only tell you one thing: when you actually anticipate any remote indication of doing EBUS TBNA, like if you want to go with the pulmonary vascular structure, and if you are planning to do EUS-B FNA, or when you are planning to do transvascular EBUS TBNA, you might anticipate a major complication. Otherwise, EBUS TBNA is a very safe procedure, having less than 2% of the complication. Most of the time, anesthetists play a very important part while doing a EBUS TBNA. But obviously, you can anticipate, or you can have a complication of sedation part also. The risk of over-sedation of a patient during the procedure, conscious sedation versus general anesthesia, and case report of apnea under propofol sedation. So how to avoid this? You need to have a very good anesthetist team, and you need to ideally appoint a team member who solely monitor the patient condition and hemodynamic status, and use adequate but safe amount of local anesthesia. Till date, we have almost crossed 900 patients underwent EBUS TBNA. I have never used any general anesthesia, nor even we have not used LMA also. Only a mask. We have just used a propofol or midas and fentanyl. That's it. So this anesthetist doctor can obviously follow the sedation scale. And when you reach at the level of 3 or 4, they need to tell you that you need to just stop doing the procedure, make sure the patient is stable hemodynamically, and then you start doing it again. So obviously, while doing EBUS TBNA, the Olympus scope have a 30-degree angulation. So you need to hyperextend and the neck, and you need to make sure that you go linearly and not 30-degree angulation, otherwise you will cause damage to the cord or upper airway. Now this was a case which was discussed before, and I think one of the doctor told that aspiration of the mediastinal cyst. But this was one of the case where mediastinal cyst was aspirated, and that caused, cyst aspiration caused mediastinal abscess after EBUS TBNA. So the pre-procedure and the post, you can see that initially it was a right hilar, and then later on there was a right paratracheal mediastinal lymph node and with the air pockets. So mediastinitis, how to avoid this? Avoid the puncture of cyst. If cysts are punctured, antibiotic should be administered. Prophylactic antibiotic when necrotic lesion is punctured. And this present case reinforced the existence of serious infective complication of EBUS TBNA. The infection is due to cross-contamination that lead to inoculation of the oral and nasopharyngeal commensal. Empirical antimicrobial therapy should include agent against active organism. So I think if the cyst is not doing anything to the patient, leave it as it is and don't try to aspirate the cyst. There was one paper showing infectious complication from full extension of TBNA needle. Now when you actually extend the needle up to 4 centimeter, then definitely it can cause pericarditis or mediastinitis. Now this was a paper where full TBNA needle was really necessary because no paper till date have described either the needle depth utilized or whether needle penetration which can improve the yield of diagnostic material. We know that when we actually enter in the middle of the lymph node, and if there is a necrotic lymph node, if it is around 3 to 4 centimeter, and if you use the full extent 4 centimeter, you can get a good material that might be used for molecular and genetic analysis, but at the cost of increased infection risk. So why it happens? So EBUS TBNA mediated contamination of the tumor bed that can include the temporal infectious presentation following EBUS, rapid expansion of the lung mass containing air pocket after EBUS TBNA procedure, development of the mediastinal or paratracheal lymphadenopathy, excellent antimicrobial response, and moreover, it was unlikely for the tumor necrosis, cavitation, and secondary infection to occur so rapidly without the initiation of chemotherapy or radiation therapy. This is what you can see over here on the left side. So there is a right lymph node and right hilar lymph node, and then there was an air pocket over there, and at the same time the right paratracheal lymph node was there. Now when you actually go with the extension of 3.6 mm or 4, obviously you can end up having a mediastinitis or pericarditis. So although the needle designed for this scope has an outer sheath to minimize the sample contamination, the sheath still passes through this working channel. And infectious complication can be due to inadequate bronchoscope processing or operator inexperience. There are well-documented failures in the bronchoscope manufacturing and cleaning procedure that has led to the procedure-related outbreaks. So I have just mentioned it that the infective pericarditis development can happen due to contamination of the pericardial space, and full needle extension must have been allowed the needle tip to enter the pericardial space to allow the pericardial contamination. And because you cannot actually see in the real-time aspiration. This is one of the esophageal perforation with EUS-B-FNA when you actually want to get the sample from the left adrenal gland. Scope damage, most frequent complication of the procedure. Very important because this is a very expensive stuff. You end up, the OT staff might tell you just sorry, but you will end up paying a huge amount of money for the repair. Very expensive complication for the department, puncture of the working channel, damage to the distal covering, damage of scope during transport and cleaning process or storage, and damage to the balloon channel. Even if you don't keep balloon, if you don't want to inflate the balloon, but keep the balloon inside. Otherwise, it can block immediately with a spillage of blood. This can, again, patient bite mark on the scope, biopsy needle perforating the sheath, needle puncture of the biopsy channel, needle puncture of the ultrasound cable, and wrong placement of the EBUS scope in the carrying tray, and puncture of the balloon. So how to avoid the scope damage? Check needle before insertion into the working channel. Insert needle into working channel with the bronchoscope in the neutral position. Take your thumb off the level. Ensure guide sheath is visible before advancing needle. Adequate training of bronchoscopist and assistant, and handling of the EBUS scope. I would just tell you one thing, that if you have a good training in a good setup, and if you have at least done roughly around 100 EBUS procedure, you will not end up making mistakes. But if you just try to do it without having a proper training, then you might end up damaging the scope inside the patient, inside the trachea, or maybe during cleaning process or during transportation. How to avoid the scope damage? So obviously you need to take out the guide sheath before taking any sample, and when you just take the sample, make sure that you see the guide sheath first. These are the few tips. Why is TBNA aspirate dry even though you puncture the correct site? Now the needle is pushing the node actually, but they are not penetrating the capsule of the lymph node. So you need to do a fanning technique. Once you start doing the fanning technique, you might able to go into the capsule of the lymph node and you will be able to take the material. Why is TBNA aspirate blood even though you punctured the correct site? Because of the vascularity of the lymph node. Why is virtually impossible to sample the AP window, that is lymph node station 5, by TBNA? Because the node lies beyond the aorta. Why might a TBNA aspirate show necrotic material and nothing else? The node may have significant necrosis, but the Doppler distinguished the 4R node from the vessel, and then it may sample only those necrotic area in the lymph node. And the pericarditis which happen after full extension of the needle, that is full length of 4 centimeter. This is one thing what we have come across a lot, that when we take the material, you just get a bronchial cells. Why it happens? Because actually when you take the sample, the bronchial wall might be aspirated as the needle penetrate through the bronchial wall. So the bronchial cells ejected by the needle stylet, which is aspirated from within the lymph node, and then you finally end up having no diagnosis. These are the TBNA associated complication we all know now, that bleeding due to puncture of large vessel, intramural hematoma, airway edema, damage to the scope, which is most common, needle breakage, pneumomediastinum, cardiac tamponade, pneumothorax, and pericarditis. So it is possible that the overall reporting of the complication may be an underestimation and all complication not recorded and reported. It has been suggested that at least 50 procedure per year is required to maintain the EBUS TBNA skills. Scientific report on EBUS TBNA are often from a large volume institution, where the low complication rate may be linked to the highly skilled IP interventional pulmonologist. The highest complication rate reported till date is 1.44. Additionally, the scope damage could be encountered in 1.33% and TBNA needle could malfunction. Utmost care should be taken to prevent the contamination of the scope, needle and the stylet to prevent infectious complication. And as the indication of the EBUS TBNA expand and its transvascular approach has been explored, bronchoscopists should remain vigilant for early as well as late complication. I have done few cases which I would show it to you just. Even if you want to anticipate something remote indication and if you want to do something out of the way, you have to have a good cardiac backup. You need to have a good ICU backup. Otherwise, you will end up having major complication and you won't be able to settle down immediately. And you might lose the patient. Remember one thing, EBUS TBNA is just a diagnostic procedure. Patient want to go back home on the same day within 1 or 2 hours. So you don't want to make any mishap that you want to lose the life of a patient. Take home message, it is more than hitting a node. Complications are rare. Documented infection, especially after cyst aspiration. Damage to EBUS scope is most frequent complication. Repeated training of staff regarding handling of the equipment. EBUS TBNA should be performed by a trained personnel. It's a teamwork and pathologist, nursing staff and MDT. We have done around closely more than 900 patients. We had our own share of complication, minor bleed, moderate. One of the patient, I had taken the sample from the right hilar lymph node, massive bleed around 300 ml of blood. I don't know what went wrong. In spite of doing initially 500 or 600 EBUS, that patient had to be taken to the ICU, intubated on multiple inotropic support. After 24 hours, the patient was doing well. Finally, after a 1 week time, she went back home. So this can happen even after you cross more number of procedures. This was one of the case. I'm just going down to the cases. Lesion is a 63-year-old male patient presenting with a CT scan showing lesion abutting the left upper lobe bronchus with abrupt cutoff of anterior segment of the left upper lobe and left main pulmonary artery. I'd asked doctor that how you need to take the transvascular approach. So this is what I did, and only after taking a short X-rays sample, and I had only choice of doing 1 or twice because I was knowing that if it bleeds, I won't be able to stop it. And finally, I got metastatic adenocarcinoma in this case. So this was done in back 2020, but I got lucky enough, and finally we made a diagnosis histopathology. So this was a lung mass, there you can see over here. One USB FNA also I tried, because after taking so many samples from subcarinal node, I could not get anything. So finally I thought, let me go down and do a USB FNM, and this was suggestive of primary benign schwannoma of mediastinum. So rare diagnosis, but obviously a rare way of doing it. And we know that EUSB FNA can also cause a complication and perforation of the esophagus. So you have to be more careful even doing that. And last case, this was a very difficult case for me, a 36-year-old guy, Eisenmenger syndrome, pulmonary artery systolic pressure of 120. And obviously RV dysfunction and RARV dilated. This patient came down with a right hilar lymph node. I had taken the BAL sample, they were all negative. I got only one chance to take the EBUS sample. Now post procedure, just once I got only one sample, and that was suggestive of granuloma. So I was a bit lucky in that. But immediately after that, the patient had a atrial fibrillation. We got lucky because we had a cardiac backup, and my twin brother is a cardiologist who managed the patient, and finally the patient went back home. But with pulmonary artery systolic pressure of 120, obviously it is going to be very difficult, and the patient was in ICU for a day or two.